So we're going to be talking about obstructive sleep apnea. And in men, it's one of the common risk factors for idiopathic intracranial hypertension, which is a risk factor also for non-arteritic anterior ischemic optic. So both the sleep apnea and the disc edema are risk factors for NAION. And so we always ask patients, all of them, but especially overweight men, big neck, about do you snore? Do you feel sleepy in the daytime? And we administer this really quick questionnaire. We use the Berlin, but there are other questionnaires you can use. We just use Berlin because it's faster. So why would obstructive sleep apnea cause disc edema? So it's obstructive, which means your airway closes. And when your airway closes, it sounds like this. And to open the airway, you must generate a Valsalva. That increased intrathoracic pressure is transmitted up into your neck and into your head. So it causes increased intracranial pressure from a mechanical obstructive. It occurs in sleep, and that means the people don't know they have it. And you've got this other thing, apnea, which causes hypoxia, decreased oxygen, but it also causes hypercapnia. And it is that hypercapnia that can cause increased intracranial pressure. Because as you know, carbon dioxide leads to the vasodilation, and that brings more blood flow because that's what your body's response on an autoregulatory mechanism is, and that will also increase your intracranial pressure. The reason it's important to know that for IIH, especially in men, is their opening pressure during the day might be normal. And so you cannot rely upon the lumbar puncture in the modified Dandy criteria for patients who have nocturnal elevation of intracranial pressure from obstructive sleep apnea, because in the daytime they have no obstruction and they have no apnea, and therefore their ICP will be normal. In addition, obstructive sleep apnea is a risk factor for non-arteritic anterior ischemic optic neuropathy. But instead of the obstruction being the mechanism, it is the hypoxia that is the problem. So for NAION, we have hypoxia. For IIH, we have obstruction, and we have hypercapnia. This is the linking mechanism, and sometimes it's hard to tell the difference between these two things, and they are not mutually exclusive. So someone could have bilateral, simultaneous or sequential NAION from IIH from obstructive sleep apnea. A causes B and C. This is not a violation of Occam's razor. And so often we end up treating for both because we can't tell the difference. And if you have papilledema, you might get NAION.